we're ready.
Okay, thanks. So good afternoon. I am Jane Schreiber. I am a pediatric neuropsychologist at the Children's Hospital of Philadelphia. And Sophie Foss is a pediatric neuropsychology resident at Boston Children's Hospital. So we're going to present some highlights from our review paper on neurobehavioral outcomes in children with myelomeningocele, which, as you know, is the most severe form of spina bifida. Next slide, please. So we will briefly review the pathophysiology, but the majority of the presentation will focus on the range of possible associated neurobehavioral outcomes. We will briefly discuss some of the contributions to the variability that we see in this neurobehavioral profile, and then end on some recommendations for neuropsychological follow-up. Next slide. So myelomeningocele affects multiple anatomical levels. As you can see on the slide, little bubbles are around the different areas involved. So we see abnormalities in the spinal cord, the cerebellum, the brainstem, the corpus callosum, and the cerebral ventricles. Approximately 90% of children with spinal lesions below the T12 level meet criteria for a Chiari-2 malformation. Those with a higher level lesion actually have a higher risk for Chiari. Abnormalities may occur in other cerebral areas as well, including things like a cortical heterotopia. And so these brain abnormalities can impact neurodevelopment and compromise aspects of neurobehavioral functioning, which we will talk more about in a minute. Next slide. Hydrocephalus is often considered to be a secondary central nervous system insult that is related to the Chiari-2 malformation. It occurs in approximately 85 to 90% of individuals with myelomeningocele who have undergone postnatal closure surgery. More about that in a second. Treatment with shunt or endoscopic third ventriculostomy is common. Next slide. So the primary treatment for myelomeningocele is surgical closure of the spinal lesion. Closure surgery most commonly occurs during the immediate postnatal period, but in utero surgical techniques allows for fetal or prenatal closure in a subset of patients who meet specific criteria. The management of myelomeningocele study, or the MOMS trial, compared prenatal and postnatal surgery and found that prenatal closure was associated with improved motor functioning, reversal of hindbrain herniation, and decreased risk for a shunt. Currently, only a fraction of patients diagnosed with myelomeningocele during pregnancy qualify for prenatal surgery, and the majority of patients continue to undergo postnatal treatments. As prenatal techniques have only been readily available during the past decade or so, the majority of research on neurobehavioral outcomes has been done with children who underwent postnatal closure. And most research examining children who have undergone prenatal closure is still ongoing. One concern related to prenatal closure is the increased risk for preterm birth, which we know can have its own negative effects on neurocognitive development. Additional treatments for children with myelomeningocele involve medical and surgical management of hydrocephalus, spinal cysts, tethered cord, and orthopedic issues, just to mention a few. And as more prenatal closure surgeries are performed, management protocols may continue to shift over time. Next slide. So next we will turn to discussing the neurobehavioral profile often seen in children with myelomeningocele.
All right, so we know that there is a characteristic profile of neurobehavioral strengths and weaknesses that we often see in myelomeningocele. So that is depicted here in a pretty complex model. So briefly, we see that this model describes two modes of information processing. So we have assembled processing, which refers to integration of information into larger unified thematic concepts, while associative processing is the grouping or categorization of information. So we'll keep these different types of processing in mind as we discuss specific cognitive domains. Next slide. Individuals with myelomeningocele typically have slightly lower IQs than those in the general population, which we see here with a normal curve. Next slide. So with no hydrocephalus, the mean IQ is about 1/2 of a standard deviation below the mean, but still within the average range. And next. Hydrocephalus is in turn associated with a decrease of about 1 full standard deviation, leading to mean scores in the low average range depicted here by the curve all the way to the left. And we know that shunt-related complications can also further negatively impact IQ. And when we break down IQ further, we find that verbal reasoning tends to be relatively stronger, while nonverbal reasoning tends to be relatively weaker. Next slide. Attention is generally viewed as a 3-part system with distinct neural networks that underlie each part. We have alerting, orienting, and executive control. Anterior brain networks serve as the substrate for alerting and sustaining attention, while posterior brain networks are recruited for attention orientation. People with myelomeningocele generally have more difficulty with orienting and shifting focus, likely due to structural and functional abnormalities in brain regions involved in the posterior attention system. In contrast, we see that sustained attention is usually fairly age-appropriate in this population, which is thought to reflect more typical anterior attention system development. Next slide. Executive functions are a broad group of cognitive skills that we think of as including self-regulation and then goal-directed or oriented behaviors. These include things like timing and speed, sequencing and planning and organization of information. So in addition to cortical and subcortical networks, the cerebellum and corticocerebellar pathways are critical neural substrates for these functions. In myelomeningocele, cerebellar dysmorphology can affect several aspects of executive functioning, including timing, sequencing of information, and organization, above and beyond the influence of IQ. Some aspects of executive function difficulty, including slower processing speed and dysregulated integration of complex information, are thought to be related to corpus callosum dysgenesis. Next slide. Language is often seen as a strength in myelomeningocele. So we know that more concrete aspects of language like grammar and lexicon are typically age appropriate. Generally, we do see more challenges with higher level verbal tasks that involve things like inferential reasoning or understanding others' meanings when it is not fully clear. So the more concrete aspects tend to be typical, while more complex or inductive reasoning is a struggle. And so these difficulties tend to appear in both spoken and written language. Next slide. Memory refers to a very broad set of neurocognitive functions, and we see that these are differentially impacted in myelomeningocele. So explicit memory is the intentional recollection of experiences or information, while implicit memory is the use of information that you already have learned without conscious awareness, like riding a bike. Prospective memory is the concept of remembering to do something in the future, like doing a task at a certain time. Then we have working memory, which is sometimes categorized as part of executive functioning, and that's kind of our mental chalkboard where you hold information in mind for immediate usage. Finally, we have rote memorization, which is the process of repeating information verbatim so you can learn it rote. So in myelomeningocele, we see that rote learning and implicit memory tend to be better developed, while explicit and prospective memory are more impaired. And this is thought to be due to disrupted development of subcortical structures and associated networks. We also see that recognition repetition tends to be stronger than independent retrieval of information. And finally, for working memory, generally tends to be intact for simple information, but declines with more complex information. Next slide. Individuals with myelomeningocele often show weaknesses in visual spatial perception, construction, and analysis. While basic recognition is usually intact, more complex spatial understanding is generally weaker. And we think this is related to both structural and functional brain changes that occur in myelomeningocele, as well as the presence of hydrocephalus, as all of these tend to exert a greater impact on the posterior portion of the brain, where many of the visual function networks are housed. We also know that the cerebellum is important for aspects of visual spatial functions like timing and sequencing of incoming information. And finally, the corpus callosum is really critical for transferring and integrating information across both hemispheres, which is particularly important for incoming visual information from both sides of the visual field. Next slide. In myelomeningocele, we tend to see impaired movement and motor functions, which are thought to arise from physiological changes to the cerebellum and the midbrain, as well as the spinal lesion level, which we know can affect ambulation. And so individuals with myelomeningocele can generally learn motoric tasks fine, but have much more difficulty with precise timing and smoothness of motor functions, which might result in dysmetria, ataxia, or dysarthria, which are imprecise or arrhythmic movements. And the combination of the motor difficulties with some of the other challenges I've already mentioned, like visual spatial deficits, can impact real world tasks like handwriting, drawing, and daily care. Next slide. Academically, we see an increased risk of difficulties. As we know, can affect both occupational and psychosocial outcomes. So concrete academic skills that tend to use more associative processing, like word decoding and spelling and math facts, tend to be easier to learn, while tasks that have more complex or flexible thinking and involve more of that assembled processing, such as word problems, applied math, reading comprehension, and essay writing, tend to be much more challenging. Next slide. Psychosocially, we see an elevated risk of symptoms that affect both mood and behavior. And people with myelomeningocele are also likely to have social difficulties, which is likely related to both decreased acceptance from peers due to overt differences and a vulnerability to bullying related to that, as well as some challenges with social cognition, which we know is associated with executive functioning difficulties. And so generally there is a strong social interest and a desire for relationships that's pretty typical, but perception of those social cues can be very challenging. Next slide. Adaptive functioning refers to daily demands like self-care, navigating the community, managing medical needs, etc. And this is really affected by an individual's specific pathophysiology, such as their lesion level or specific motor needs, as well as their environment, so how much help they have from parents or healthcare workers. And so while we know that children with myelomeningocele can typically learn discrete adaptive skills, the typical difficulties with executive functions like planning and cognitive flexibility can thus impact how they're able to generalize those skills to new contexts or adapt to any changes that might arise, leading to trouble with that sort of real world adaptive functioning. Next slide. So overall, we see this combination of strengths and weaknesses across domains related to what I discussed before, the strengths in that more of those associative processing domains and challenges in assembled processing. So this is what we call the sort of quote unquote modal profile. It is really important to remember though that individual presentation varies quite a bit due to an individual's variability in both their medical and physiological presentation, as well as environmental factors. So we'll discuss that next. Next slide.
So from a medical standpoint, most neurobehavioral outcomes tend to be worse in children with shunted hydrocephalus. If you look at this graph or these set of graphs from a paper by Hampton and colleagues, on the left, you'll see lines comparing performance across cognitive domains. Along the bottom are different cognitive domains in children with spina bifida. Those with shunt-treated hydrocephalus are represented by the blue line along the bottom, and children with arrested hydrocephalus that is untreated are represented by the red line, and children with no hydrocephalus are represented by the yellowish green line. The purple line at the top is performance of controlled children who do not have spina bifida, and higher scores are better performance. So you can kind of see that pattern play out here. On the right is a figure that summarizes across all cognitive domains and shows that children with shunt-treated hydrocephalus really perform the worst across most categories. Next slide, please. However, this next graph from a subsequent paper by Hampton and colleagues indicates that hydrocephalus is not the whole story. So this paper examined cognitive functioning in children with spina bifida and shunted hydrocephalus, which is represented by that red line, and compared that group to two groups of children who have shunted hydrocephalus due to aqueductal stenosis and not spina bifida. So the blue line represents children with aqueductal stenosis and cerebellar dysmorphology that was detected by neuroimaging. And the yellow line represents children with aqueductal stenosis and no cerebellar dysmorphology. And the gray line, again, at the top is a group of control children. So as you can see, the children with aqueductal stenosis and cerebellar dysmorphology perform more similarly to the children with spina bifida and shunted hydrocephalus, suggesting that the cerebellar abnormalities further compromise these neuropsychological outcomes. Next slide, please. So the table on this slide is from a recently published paper from the follow-up study of the MOMS trial that I mentioned earlier. And this is during the period when the participants were about early school age. So children who underwent the prenatal surgery performed better on tests of reading ability and fine motor skills, which is what the arrows are pointing at. It's hard to see because there's so much on this slide. But interestingly, the rest of the results did not indicate much difference in cognitive functioning in the children who underwent prenatal versus postnatal surgery. The pattern of cognitive results across both groups indicated better reading than math, impaired visual motor integration, and higher verbal than nonverbal IQ scores, which is actually fairly consistent with the modal profile that we just described. Notably, the prenatal group was found to have a higher rate of ambulation, better sensory motor function, and reported a higher quality of life. There are some ongoing analyses from these data that are examining the cognitive differences related to hydrocephalus status. And we're also currently awaiting grant approval for the third follow-up of the MOMS trial when participants are now adolescent age, and that study will include more measures of attention, executive functioning, and independence, which were not included on the prior follow-up. Next slide, please. So with regard to environmental variability, the child and family's race, ethnicity, socioeconomic status, and level of family cohesion or conflict have all been found to influence outcomes. It's important to note that this is actually not unique to spina bifida, but is frequently seen across many medical conditions. These environmental aspects are thought to be associated with outcomes because of the multi-directional nature of how a child and his or her environment influence one another. So such that the children with specific experiences interact with their environments differently, in turn shaping their learning experiences. So you see this very complex and kind of hard to read figure on the slide is really just put up there to illustrate these complex multi-directional relationships. Next slide, please.
So finally, we don't have a lot of time to discuss these in detail, but these are recommended guidelines from the Spina Bifida Association for neurodevelopmental follow-up at specific age points for individuals with myelomeningocele. And so these include following different cognitive, language, and academic and vocational achievement milestones. And so we will go ahead and stop there for today. Thank you all so much for your time, and we're happy to answer any questions about any of the information we've presented.
Thank you both. So a question came in. There's an older literature that suggests that Ritalin-type drugs improve performance, in particular in math in MMC children, myelomeningocele. Any thoughts on how this information can help guide therapy?
So that is a good question. There's also a literature to suggest that because of how these children's attention deficits originate, that they don't have the same pattern as was mentioned as children who have more traditional ADHD, and that these drugs, because of that, these drugs may not be as effective. That doesn't mean that we would not recommend a trial if it seemed like the child could benefit from it, though. It's always sort of a case-by-case basis.
And I think also because the role of attention in learning is so critical, if attention is the primary concern and you're able to improve the attention symptoms somewhat, that may allow for more learning and more engagement in the academic skills as well.
And I think we can squeeze in one question if anyone has one, but if not, okay. Thank you both for presenting. This was really, really interesting. And thank you for coming. And I guess we're going to move on to Dr. Allen. You are next. So I'm going to pull up your slide.